بسم الله الرحمن الرحيم. أهلا بكم. Our talk today will be about very important topic in cardiology and in heart failure in specific. The topic is heart failure with preserved ejection fraction or HFpEF. What should you know? This is an evolving disease category now in cardiology, and you will hear every now and then about HFpEF. What is this syndrome? What is the pathophysiology? What is the diagnosis? I will go through all these. Hopefully, everyone can benefit from my presentation. Let us start by this clinical case first, as a kind of brainstorming. A 75-year-old woman present at your clinic with increasing shortness of breath and fatigue for the last 4 months. She has NIA class 3, has long-standing hypertension, type 2 diabetes, and chronic kidney disease. Her physical examination revealed BMI of 33, blood pressure of 130/65, pulse rate of 80, unable to visualize the neck veins, and she has one positive or 1 plus ankle edema. N2 proBNP is 1550, and her EGFR is 42, and her ejection fraction is 60%. LVH with LV volume index, left atrial volume index around 35 ml per meter square, and E over E prime is 10. Is this patient having HFpEF? Keep it now in your mind, and I will come to it soon, inshallah. So what is HFpEF? The definition of HFpEF is very easy. It's heart failure with preserved ejection fraction. This is HFpEF. So what do we need? We need symptoms and signs of heart failure plus evidence of preserved ejection fraction. Here is the question: what is preserved ejection fraction? The ESC guidelines for heart failure published in 2016 was very affirmative in this for the first time, and they classify heart failure to 3 main groups: patients who are having heart failure plus ejection fraction below 40, and they call them HFrEF, heart failure with reduced ejection fraction, and then patient with half mid-range ejection fraction, means borderline ejection fraction. So the symptoms and the signs of heart failure plus ejection fraction between 40 and 49. And then HFpEF, as I said before, ejection fraction should be above equal to 50 or above 50, equal to or above 50. But you need some other information to diagnose heart failure in those two groups. You cannot say symptoms and signs and ejection fraction only. You need to have evidence of the diastolic dysfunction, either by the biomarker, at least the biomarker should be elevated, natriuretic peptides, NT-proBNP or BNP, plus evidence of structural heart disease by echo, especially LVH or left atrial enlargement. You should have evidence in both in HFmid-Ref and in HFpEF. So this is the conditions which should be fulfilled to diagnose HFmRef. I mean half mid-range, so I will label it as HFmRef, and HFpEF, which is heart failure with preserved. So we have HFref reduced, HFmRef mid-range, and HFpEF preserved. How is it prevalent? Is it common disease or rare disease? Really, it's a very common disease. Yani, can you imagine HFpEF now is almost 50% of the population of heart failure in general. So as you can see, the trend for incidence and the prevalence of heart failure with preserved ejection fraction is increasing. And if compared with HFrEF, the blue is HFrEF, the red is HFpEF. So the trend is for HFpEF is increasing, and the trend is for HFrEF is declining. Are talking about 50-50 now, or even more than 50% for HFpEF. As you can see here in another registry, this one registry is, as you can see, this is the HFrEF trends, and this is the HFpEF trends. It's increasing in favor of HFpEF. The half mid-range is plateauing, almost the same. In the Middle East, I have this registry published a few years ago from Saudi Arabia, and as you can see, the syndrome. This registry, this was the preliminary phase, but the actual registry was around 2,600 cases, and the incidence of HFpEF was 27% in the acute setting and 24% in the chronic setting. And this is published in the European Journal of Heart Failure, and also the main article published in the same journal, showing that this syndrome of HFpEF is underrepresented in Gulf population in general, because we have the same finding also from the Gulf Care Registry, another 5,000 patient registry. So why it's underrepresented? I say mainly because of the younger population of heart failure in the Middle East. As we know, heart failure is happen earlier in patients in the Middle East, and we know that HFpEF is the disease of elderly. That's why it's underrepresented, and also because we don't have enough resources to recognize all HFpEF patients till now in the community, as we know. Data from Egypt also. I have this article published recently with one of my juniors, Dr. Sharif Shaheen, just published recently in 2020. And as you can see, patient with heart failure and the preserved ejection fraction are around 40% of the population. So patients who are having ejection fraction below 40 are around 62%. So even in Egypt now, despite the limited resources we have, but actually we are diagnosing HFpEF every now and then now, and I think within coming few years, HFpEF will be equal to HFrEF. Who are this patient? This patient, as you can see from the ADHERE registry, which around 150,000 patients from the US, and this is the two analyzed patient, the two analyzed cohort. They analyzed 26,000 patients with preserved and 25,000 patients was reduced. The age, as you can see, higher in HFpEF. The women mainly in HFpEF, so most of the HFpEF are women. We're talking about 62% for women are HFpEF, but in HFrEF they are only 40%. Hypertension is more in HFpEF than HFrEF. Atrial fibrillation is higher also in HFpEF than HFrEF. COPD and asthma higher. Coronary artery disease, on the other hand, is lower, is less. So 50% only in HFpEF, but 60% in HFrEF. MI history, of course, less in HFpEF than HFrEF. So it's clear that those patients are elderly, are women having multiple comorbidities and the atrial fibrillation. So in summary, they are elder, they are mainly women, and they have increased prevalence, and also comorbidities are more clear in those patients. What is the pathophysiology of HFpEF? It is the same as HFrEF. Actually, يعني, there are big differences between HFpEF and HFrEF. Classically, we know that the main problem in HFrEF is the systolic dysfunction and left ventricular enlargement, chamber enlargement, and eccentric hypertrophy. But in HFpEF, we have a smaller cavity, we have thicker myocardium, we have diastolic dysfunction. So the main issue here is the muscle sickness, concentric hypertrophy, left atrial enlargement, and diastolic dysfunction on top, or diastolic dysfunction at the cause of that. Here, the main issue is in the left ventricle dilatation and the systolic dysfunction. This is to speak generally about the differences between the two pathophysiologies. Aging is the cornerstone of pathophysiology in patients with HFpEF. It's a disease of aging, as you can see. Aging, there is accumulation of many comorbidities, including sedentary life, poor fitness, hypertensive remodeling, obesity, metabolic stress, diastolic dysfunction, and global loss of cardiac, vascular, and peripheral reserve. All of these will end by HFpEF. So heart failure with preserved ejection fraction is the disease of comorbidities. As I said before, we have non-cardiac morbidities and we have cardiac morbidities. All these happen in HFpEF patients. As you can see, the non-cardiac morbidity, including lung, anemia, renal, aging, obesity, depression, the cardiac causes, including the stroke dysfunction, atrial dysfunction, atrial fibrillation, autonomic dysfunction, chronotropic incompetence. Those patients usually are on the bradycardic side, so and they cannot tolerate bradycardia. So I will come to this in the treatment. Vascular dysfunction is central in the pathophysiology of heart failure. Vascular stiffness, especially central arterial stiffness, aortic stiffness, are common in those patients, and also ventricular arterial coupling is impaired in those patients as well, plus hypertension and inadequate control of the blood pressure, plus pulmonary hypertension. Pulmonary hypertension also happen in the end stage of this disease and is part of the pathophysiology, mainly due to the diastolic dysfunction. Valvular disease, mitral regurgitation could happen as well, and contribute to heart failure in those patients. Not only this simple pathophysiological mechanism, but recently we're speaking now about systemic inflammation. As I said before, it's a general systemic condition, including metabolic syndrome, obesity, type 2 diabetes, and hypertension. This metabolic syndrome is a precursor of inflammation, precursor of inflammatory process, together with renal insufficiency. This will activate many inflammatory mediators, CRP, interleukins, and this will end by multi-organ affection. So the heart is part of this multi-organ affection. So you cannot say it's a pure cardiac condition. That's why we're saying HFpEF is not a pure cardiac condition. Even we might question the existence of this syndrome from the start, is it present or not. So simply I can say that HFpEF start from the blood vessel, start from the inflammatory mechanism, start from the microvascular inflammation, the cellular dysfunction, and then the heart is affected by the histology and the stroke dysfunction. This is so start peripherally and end centrally. The opposite happen with HFrEF. HFrEF usually start from the heart itself, myocardial infarction, myocarditis, whatever. And then the vessel is affected later by vasoconstriction, increased afterload, and neurohormonal blockade. So it's clearly we are facing two different mechanisms, but they are interacting at certain points. You cannot say they are totally separate, and you cannot say they are typically the same. There is interaction at certain point between HFpEF and HFrEF, but there is some separation in the pathophysiology. And this is the clearly the dilemma. This is the dilemma. Is HFpEF a transitory stage to HFrEF, or HFpEF a distinct entity from HFrEF? This paper published in 2014 by Professor Michel Comajda from France. And as you can see, he was more biased to the idea that HFpEF is a distinct entity from HFrEF, depending on the bimodal distribution of the LV ejection fraction and the distinct pattern of LV remodeling. As we say, in HFrEF is eccentric hypertrophy, in HFpEF it's concentric hypertrophy, and also distinct cellular and subcellular and the interstitial characteristics, including the collagen metabolism, which is different between two conditions, and also the structure of the myocyte itself is different between HFpEF and HFrEF. And also the most important is the distinct response to heart failure therapies and trials. Most of the medications failed to show benefit here, but it succeeded to show many benefits here. This is why Dr. Comajda was biased toward the being a separate intent entity. But I will tell you later, it was a very important trial, the Paragon study, which is published last year, and showed many benefits in patients with half mid-range that may be this theory is different now or changed now. Again, this is the to complete the pathophysiology and to understand the pressure volume relationship in patient with HFrEF and HFpEF. As you can see in HFrEF, the main problem is in the volume. This is the volume. There is increased volume, and here the Frank-Starling mechanism work. This is why those patients tolerate vasodilatation and tolerate many drugs other than patient with HFpEF. HFpEF, there is no problem with the volume. The problem with the pressure, the steep relationship, the steep end systolic pressure volume relationship in HFpEF compared with HFrEF is almost flattened, almost plateau, but here is a steep relation. This is why when you give vasodilator for HFrEF, the patient benefit and the cardiac output increase, and the blood pressure minimally decreased. But when we give vasodilators to patients with HFpEF, as you can see, the cardiac output is decreasing, and the blood pressure is affected more by lower blood pressure more in HFpEF than HFrEF. This is the effect of vasodilatation on both syndromes. So this is to understand how much differences between the two entities in pathophysiology. How can we diagnose HFpEF? Again, from the same figure from the ASC guidelines in 2016, we need symptoms and signs of heart failure: dyspnea, proximal nocturnal dyspnea, orthopnea, exertional dyspnea, GVBs, lower limb edema, hepatojugular reflux. All these should be present, or some of them, of course, not all. Plus evidence of preserved ejection fraction, either above 50 in HFpEF or 40 to 49 in HFmrEF, plus evidence of elevated peptides and additional structural heart disease evidence, either LVH or left atrial enlargement. I myself like left atrial enlargement. Left atrial enlargement is more than enough parameter by echo to diagnose structural heart disease. So if you have only left atrial enlargement plus all these characters, you are done. You have diagnosed HFpEF. This is the echo characteristics of those patients. As I said before, LV, left atrium volume index, should be above 34 ml per meter square, and left ventricular volume mass, LV mass index, LVMI, above 115 gram per meter for male and above 95 gram per meter square for female, and the E over E prime should be above 13, despite in other reports should be above 10 or even above 9. So this is a little bit higher. And the mean A prime should be below 9 centimeter square. This means severe diastolic dysfunction. When the E prime below 9, this means severe diastolic dysfunction. And when the E over E ratio above 10 or above 9 or above 13 in this report, it's a severe diastolic dysfunction. Diastolic stress test, what does this mean? This means if we cannot elicit any diastolic dysfunction during rest, thus you can exercise the patient on a semi-bicycle, on a semi-supine bicycle ergometer, and there is exercise protocol for that to assess the LV E over E ratio, the pulmonary artery pressure through the tricuspid velocity, and also systolic dysfunction by longitudinal strain. So with this protocol, you should depend on the longitudinal strain, not the ejection fraction, and the stroke volume and the cardiac output changes with exercise. So this is the diastolic stress test to elicit this parameters during exercise على ergometer على bicycle. ECG in HFpEF. If the ECG is normal in HFpEF, this is very unlikely to be HFpEF. Usually, patient with about 90% of patients with HFpEF should have abnormal ECG. If you have normal ECG in this situation, this sign is a very good negative sign to rule out HFpEF, especially if combined with negative biomarker. Negative biomarker plus normal ECG is enough, more than enough, to rule out HFpEF. There are some certain scores has been developed. One of them is the HFpEF score. This is score published in 2018, and it depends on mainly clinical parameters and some echo parameters. So clinical and echo parameters. So what are the clinical parameters? Atrial fibrillation. Some cardiac and non-cardiac parameters. So the cardiac parameters are atrial fibrillation, E over E ratio, pulmonary artery systolic pressure. This first time to be included first time to include this in my presentation. Left atrial volume index and N2-proBNP. We know this very well, and we know this. This is new, and we know this, and we know this. The clinical non-cardiac parameters are body mass index above 30, age above 60, treatment with 2 or more antihypertensive, diabetes or pre-diabetes, chronic kidney disease, stage 3 or greater. If we have these parameters, the patient is heavy, means he has higher body mass index, hypertensive, so this is H2, heavy hypertensive, atrial fibrillation is F, and pulmonary hypertension is P, elderly E, and F is feeling H2 half بيف و2 على H، يعني هو سكور خاص بالهاف بيف بس حاطين 2 H اللي هو heavy وhypertensive to be easy remembered. This is the score. You put very high score for the atrial fibrillation, or talking about 3 points, and 2 points for the being heavy, being obese. So obesity and the atrial fibrillation only themselves have 5 points, obesity and atrial fibrillation. So once you have elderly obese patient with atrial fibrillation and you find the ejection fraction normal, might be enough to diagnose HFpEF or to predict HFpEF. To predict HFpEF is a more accurate term. If you have 7 points, you have around 95% probability of having HFpEF. This is the HFpEF score for HFpEF. Again, back to the clinical case. So we have 76-year-old woman, diabetic, hypertensive, chronic kidney disease, obese, N2-proBNP is high, and she has normal ejection fraction and the positive LV, left atrial volume index, and the positive E over A prime. So this is typical case of HFpEF that you will see in your practice, and we'll come to the management now. So again, to diagnose HFpEF, you need the symptoms and signs of heart failure. You need to have proof that the elevation function is normal or preserved, or at least you can say above 40 if you are including a HFmREF in this group. And also you need to have proof for LV vascular dysfunction, either LV hypertrophy or left atrial dilatation or other echo parameter, plus biomarker. Don't forget the biomarker. What is the prognosis? Unfortunately, the prognosis of HFpEF is as similar as HFrEF. So according to this observational study, the survival for HFrEF and the HFpEF is almost the same. And according to this Canadian observational study as well, the survival of HFpEF a little bit better than the survival of HFrEF. The most important in this issue is the incidence of non-cardiovascular disease is higher in HFpEF than HFrEF. So a patient with HFpEF died from many causes other than cardiovascular causes. I have been part of this article published in 2020 about the mortality and the morbidity in HFrEF and HFmREF and HFpEF in patients with diabetes in the Middle East. This were around, we're talking around 2,000 patients. There were around 2,000 patients, more than 2,000 patients. And this is the mortality. As you can see, I will focus on the 12 months mortality. Forget about the 3 months now. The 12 months mortality in this group, we're talking about for HFpEF 10%, for HFrEF it's 11%. So there is no difference between both. categories. Look to the hospitalization for both group. In half RF, it's 28% in 12 months, and in HFpEF, it's 32%. So even though the hospitalization was higher in HFpEF patient in our group, and this is a very good group. I will talk about 2,000 patients. How can we treat it? Do we have effective therapy for HFpEF? The answer no. Big no. Multiple no. Unfortunately, what we have achieved in patients with HFrEF, what they have achieved from many medications that improve the survival, improve the morbidity in HFrEF patient, failed to show the same level of benefit in patients with HFpEF. And as you can see, most of the studies published to date, the results are neutral or just minimal trend toward this benefit in patients with HFpEF. This is totally different from what we have in HFrEF. HFrEF, as you can see, many groups of medications, ACE, ARBs, beta blocker, mineral receptor antagonist, ARNI, all of these groups have showed many benefits in patients with HFrEF and did not show benefits with HFpEF. The most important thing is to think about prevention. This is very important because treating hypertension by itself only will prevent 50% of heart failure. 50% of heart failure could be prevented by the proper treatment of hypertension. If we bring group of patients with properly treating them and compare them to the patients who are not properly treated, we'll see that heart failure is prevented in about 50% of the population. This is huge, even better than prevention of strokes and the prevention of cardiovascular diseases, cardiovascular deaths. So, is there an ideal systolic blood? Actually, this is study from the iPreserve study, because we're worried about the ideal blood pressure for patients with HFpEF. From data from the iPreserve study, it's clear that those patients cannot tolerate lower blood pressure. And the best blood pressure was achieved in the range of 130, 140, or even 120, 130. So we're speaking about higher blood pressure than patient with HFrEF. Also, what is the ideal heart rate in HFpEF? As I said before, those patients cannot tolerate lower heart rate. So the ideal heart rate could be around 70 beats per minute. Lower than this, the patient could have harm. Higher than this, the patient could have harm, of course. So those patients better to keep their blood pressure around 120, 130, and to keep the heart rate around 70. What about other hopeful therapies? There are many hopeful therapies, not many, sorry, few hopeful therapies. One of them is very classic therapy, spironolactone, which, this is old study, but there is many analysis about this study showed that spironolactone could be beneficial. Basically, the TOPCAT study is the study for spironolactone in patients with HFpEF. It's a placebo-controlled study, double-blind placebo-controlled study. And as you can see, the number of patients were around 3,000, more than 3,000 patients. And the study in general, all in all, were negative study. So there was no benefit in terms of cardiovascular deaths or heart failure hospitalization or resuscitated cardiac arrest. This is a combined endpoint. Spironolactone in the whole population, all in all, did not show benefit. But with the sub-analysis of depending on the geography, they found a very amazing result that a patient from US, Canada, and South America showed benefit, clear benefit, with around 18% relative risk reduction in the probability of mortality and cardiac endpoint, cardiovascular deaths, heart failure hospitalization, and resuscitated cardiac arrest. But no benefit at all from the group coming from Russia and Georgia. Very big difference. This is why some authorities has depended on this sub-analysis to recommend that spironolactone should be considered This is high recommendation. It's almost class 2A in patient with HFpEF who have reasonable kidney function and reasonable potassium level. So this is the highest recommendation ever for patient with HFpEF, of course, other than control of blood pressure. What about ARNI? As we know, ARNI, angiotensin receptor polymerase inhibitor, are a new group of medications that potentiate the benefit of natriuretic peptide system plus blocking the renin-angiotensin aldosterone system, so it prevents vasoconstriction and promote vasodilatation. And the drug, we already tried sacubitril valsartan in the landmark study, the paradigm heart failure study in HFrEF patient, and everyone knows that this drug achieved marvelous result by reducing the mortality by around 20% if compared with enalapril. The sacubitril valsartan has been tried in the Paramount heart failure study. It was a surrogate endpoint study targeting the NT-proBNP reduction. The Paragon heart failure study is a huge landmark study published last year, and the Parallax study is a coming study, not published yet. I will come quickly through all these. So the Paramount study was a simple study, just comparing sacubitril valsartan versus placebo versus valsartan in patient with HFpEF, and it's published in 2012, so almost 8 years ago. And the endpoint was reduction in the NT-proBNP over a period of up to 36 weeks. As you can see, the result was in favor of sacubitril valsartan, who succeeded to decrease NT-proBNP significantly than valsartan over a period of 36 weeks. The Paragon heart failure study, that's published recently in 2019 in the New England Journal of Medicine, and included the biggest number of HFpEF patients studied until now, almost 5,000 patients. Randomized to either sacubitril valsartan with a target dose of 200 mg BID or valsartan with a target dose of 160 mg BID. So the same design of the paradigm heart failure study, but with the comparator was valsartan, not enalapril as the paradigm. Of course, as was expected, the study was negative, and the study missed the target endpoints on a very close number. The p-value was 0.059 with 13% reduction in the risk of the primary endpoint. I'm saying as expected because this is a trend in all HFpEF trials. Unfortunately, most of them are missing the significance in a very borderline, with very borderline p-value. But strikingly here, the sub-analysis was very specific and a new sub-analysis for a patient with the Paragon, where they found that women have a clear benefit from sac-valsartan if compared with valsartan, with around 27% relative risk reduction in heart failure hospitalization and cardiovascular death. Reduction in the endpoints was clearly in female if compared with male, which was not significant at all. And also with the sub-analysis of the ejection fraction, they found that patient up to the limit of 57% ejection fraction, they still have benefit from sacubitril valsartan compared with enalapril, compared with valsartan. So these two subgroups, patient with lower ejection fraction between 40 and 57, and female, clearly benefited from sacubitril valsartan if compared with valsartan. The Parallax study is a coming study. Here we know that we believe now, we realize now that it's very difficult to achieve a clear mortality benefit by using this kind of neurohormonal blockade in patient with HFpEF. So they tried now the sacubitril valsartan in a triple arm study versus ACE inhibitor versus ARB versus placebo, triple arm study. And the endpoint now is mainly the N2-proBNP and the quality of life, the exercise function, and the safety and the morbidities. So we are not targeting mortality now in this study, just we are targeting surrogate endpoints. We're waiting with this study, and I think it might be new hope for patients with HFpEF, because as we know, those patients are very elderly, and actually the main problem with them is the quality of life, is the symptoms, is the hospitalization, and not the mortality at all. This is the real situation. HFpEF, we are still driving a very old car. There is no still a magic medication that can help until now. We are waiting for other classes of medication, maybe SGLT2 inhibitors. We are waiting for studies in this group. All of this will be published soon, inshallah. There are also speech about talk about some devices that produce shunt of blood from the left to the right. Still, all of these are experimental and no any recommendation regarding them until now. So, in summary, this is the guidelines. So the most important thing is to control the blood pressure, systolic and diastolic blood pressure in patient with HFpEF, then to treat volume overload by diuretics, and to control the heart rate in patient with AFib, and to rule out any coronary ischemia. This is the most important 4 points in patient with HFpEF. And also, if you're gonna use antihypertensive, better to use ARP, depending on the CHARM study, because there was trend towards decreased hospitalization in patients with HFpEF. And according to the Paragon, I'm expecting that sacubitril/valsartan will have the same level of recommendation as ARP, might be 2A for women and for half MREF, might be. So make sure the diagnosis is correct. Make sure the volume status is optimized. Make sure you, if there is ischemia or not, and also address all the comorbidities in those patients. So in summary, HFpEF comprise almost one half of patients with heart failure, and the prevalence is continuing to increase. In HFpEF, the main driver of myocardial dysfunction comes from systemic comorbidities and endothelial inflammation. LV diastolic dysfunction from LV stiffness and abnormal relaxation is a fundamental mechanism for HFpEF. There is a higher rate of non-heart failure readmissions is observed among patients with HFpEF when compared with HFrEF. Many completed clinical trials in HFpEF have failed to meet these primary endpoints, and none have shown convincing mortality and morbidity benefit. In the Paragon heart failure study, sacubitril/valsartan reduced the primary endpoints of cardiovascular death and heart failure hospitalization by 13%, but narrowly missed the statistical significance. In the Paragon as well, there was more pronounced effect on predefined subgroups, namely women who had 27% relative risk reduction, and in individuals with lower ejection fraction, less than 57%, had 22 relative risk reduction. Thank you very much. I hope you have benefit from this presentation. If you have any question, just put it in the comment and I will answer it, inshallah. Thank you very much.